Hello, friends. I'm Dr. Harvinder Singh. Welcome to our next video podcast. And topic for today is how long to continue antidepressants for in the treatment of major depressive disorder. This is one of the few podcasts which is relevant to both physicians and patients. So, in this podcast, we will very briefly discuss the duration of treatment with antidepressant, when to continue antidepressant for little longer, and when to consider discontinuation. But before we discuss that, I just want to briefly talk about something more clinically relevant. So, before we consider medication for depression, we need to be aware of the severity of depression that someone is struggling with. What that means is you need to have at least a scales done for depression severity before you consider adding medication. There are many scales out there. Most commonly used is HAMD, Hamilton Depression Scale, and many of you know the DSM-5. Please read this to grade severity of depression. So DSM-5 grades DSM based on the number of symptom criteria and also on the severity of each symptom. And third is on the degree of a functional disability due to these symptoms. But regarding the severity, we have mild, moderate, and severe severity for major depression. And based on this severity, we decide if medications are indicated or psychotherapy is indicated. To make it more confusing, I will say there are four major guidelines for major depression. So, American Psychiatric Association (APA) have this practice guidelines for major depressive disorder. So APA recommends psychotherapy or medication as monotherapy for mild and moderate severity, but medication as first line for severe major depressive disorder. Whereas we have Australian and New Zealand guidelines for psychiatry, and they recommend medications as first line for severe depression, whereas you can use psychotherapy for mild and moderate. And when you look at the Canadian guidelines, CANMAT guidelines, CANMAT, they talk about using medications for moderate and severe major depression, but using psychotherapy for mild severity. And the last, which is European NICE guidelines, NICE, they talk about same using psychotherapy for mild, whereas psychopharmacology for moderate and severe depression. So what what I'm trying to say is psychotherapy is a good option for mild and moderate, but medications are very helpful for many patients. And this is what we will talk about as to when you initiate someone on antidepressants, how long should we continue them for? And this is what our topic for today is. Very, very clinically relevant topic. How long will you continue antidepressants for in the treatment of major depressive disorder? So let's discuss various stages of treatment for major depressive disorder. So when you start someone on an antidepressant, the first phase is the acute treatment phase. During this, our goal is the resolution of the depression symptom, and mostly the duration of the antidepressant treatment during acute phase is for 6 to 8 weeks, which is close to sometime 1 month or 2 months. It depends on the timeline for medication's onset of response and resolution of symptoms. And as I just mentioned, please use any rating scales to assess for clinical response. Most commonly used scale is the Hamilton Rating Scale for Depression, HAMD, and there are many criteria for remission guidelines for depression. For example, with HAMD that I just mentioned, if you are measuring HAMD and following somebody on HAMD, once the total score is less than or equal to 7, that is one of the criteria for remission based on many studies, or more than 70% improvement in any other patient-rated scale that you are using. So very important clinically relevant fact here is use the treatment for this much duration, but please measure the improvement with any scales before starting antidepressant and during this treatment. So this is our first phase, acute treatment with antidepressant for 6 to 8 weeks till you meet the resolution of symptoms or criteria for remission. So you have met that criteria. After that, the next phase is continuation of antidepressant treatment for total of 4 to 9 months. Now, this is very, very critical, very, very important phase. The reason why we do this is to ensure complete resolution of the major depressive episode that has happened, and also to prevent relapse. Preventing relapse is one of the important goal of continuation of antidepressant treatment for additional either 4 or maximum 9 months. And again, you measure HAMD or any other scales during this time to do that. And there are many studies done to prove this point. And studies have shown us that first 6 months following recovery from major depressive episode, the relapse risk is highest. So that first 6-month period is very, very high risk period for somebody to go into relapse. So monitor closely for any signs of relapse during this continuation phase. And most guidelines recommend that you continue somebody on same dose and same medication at same frequency during the continuation phase that you were using in acute phase. So after somebody is showing improvement in the symptom, you have two options. First option is to go into the next phase, which is called maintenance phase. And this phase can last for 4 to 5 months. But the other option is to discontinue the treatment. And in next few minutes, we will discuss the risk factors we need to consider regarding these steps. But let me go back to the maintenance phase for a minute. So maintenance phase is not indicated for every person, but this is done to prevent the development of new episode or the recurrence of major depressive episode. And we will discuss the risk factors that you need to look for in a patient regarding this decision. And the second we talked about is if maintenance phase is not indicated and patient is stable and they don't have the risk factors that we will talk about, then you can discontinue the medication. And whenever you discontinue any antidepressants, do a slow taper. Don't do abrupt discontinuation, and always monitor for withdrawal symptoms from antidepressants. And same thing, either you discontinue after continuation phase or after maintenance phase. So now let's discuss. The next point here is, when will you consider moving somebody from continuation phase to maintenance phase rather than discontinuing antidepressant? And I made this table. These are the 6 main risk factors that you need to be mindful of. And if you see any of these, consider maintaining them after continuation phase for additional few months. And these risk factors are: number one, you need to look at the frequency of depressive episode. What that means is if somebody have 3 or more prior major depressive episode, you need to do a maintenance treatment in these patients because the risk of relapse is high here. And second is the depressive episodes or symptoms. Here, I think this is very well known fact. If the severity of the prior episode is high, that it's in a severe range, you will consider doing a maintenance treatment. If there was additional psychosis, major depressive disorder with psychotic features, you will consider choosing maintenance treatment. If the suicide risk was there or suicidal attempts have happened, you should consider maintenance treatment in that. And also, in the depressive symptom, if a person have a residual or subthreshold symptoms persistence, then maintenance treatment is a good option because there is evidence that patients who do not completely recover during the acute treatment phase, they have higher risk of going into relapse. So whenever you see persistence of residual symptoms or subthreshold symptoms, consider the maintenance treatment rather than opting for discontinuation. And also, the another interesting point here is if a patient, after reaching the continuation phase, have persistence of sleep issues, sleep disturbance, then maintenance treatment is very much indicated. Sleep is very, very important. I talk to my patients a lot about this. Sleep and anxiety are very important risk factors for depression improvement, so don't ignore that. I have not mentioned here, but even anxiety or any other psychiatric comorbidities are risk factors, so you need to be mindful of that. Now, going to risk factor number 3 here is the age of onset. Studies have shown that earlier age of onset of major depressive disorder is a risk factor. If you see that, consider opting for maintenance treatment rather than discontinuation. And then number 4 is a family history of mood disorder is a risk factors. Always weigh risk and benefit in choosing a maintenance treatment in these factors that we are talking now. And then psychosocial stressors, if somebody have the ongoing psychosocial stressors that resulted in the major depressive episode on first place before you start antidepressant, and those stressors are still ongoing, consider maintenance treatment. So one thing you will notice here is the importance of keeping the biopsychosocial model of depression in mind here. It's not always biological, but you always have to consider the psychological and the social aspect of depression treatment. And this is what we are talking here, the psychosocial stressor. And the number 6 is the cognitive style, primarily the negative cognitive style. We all know with severe or with major depressive disorder, the cognitive distortions primarily of the negative thinking dominates. That's where the CBT kind of psychotherapy comes into picture and is helpful for many people. So these were the 6 important risk factors you need to be mindful of. If you see these factors, consider opting for maintenance treatment rather than discontinuing after continuation phase. So friends, this was a very short video podcast. These are the references that I used to compile this information. And this video podcast is available on our website, Psychiatry Education Forum. It's available on our YouTube channel. Do subscribe to the channel if you have not done already. And this is one of the newest chapter in our course, Physician's Guide for Clinical Psychiatry course. We have more chapters on we have a big section on major depressive disorder. I think we have more than 20 chapters there in that section alone. And this chapter will be our 232nd chapter, if I'm not wrong, in this course. So do consider subscribing to the course if you have not done already. And to stay up to date with our posts, our course chapters, our videos, do join our weekly newsletter. It's free. I'll put the information below. So thank you again, friends. I'm Dr. Harvinder Singh. These are our social media platforms. Do follow us on Facebook, Twitter, YouTube, LinkedIn, and Instagram. This is my email. Contact me if you have any questions. And I love to hear from all of you regarding this video podcast. If you have additional clinically relevant points, please reply below. So thank you again. You all have a good day. Take care. Bye.